Good afternoon, everyone. This is Diana Arias with the Community Technical Assistance Center. I would like to welcome you to today's webinar, Part 2, Best Practices in Training and Treatment of Infant Early Childhood Mental Health Concerns. Today's webinar is the second of a two-part offering on infant and early childhood mental health. In order to understand and treat the developmental, behavioral, and relationship needs of the child, clinicians and providers must focus on the parent-child relationship. Early childhood mental health intervention requires working with parents and young children together in a way that helps attend to the needs of both, together and separately. This webinar will focus on skills and competencies providers need when working with parents and young children and strategies for supporting healthy social-emotional development. Attendees will be introduced to the New York State AIMH endorsement, a credentialing system that supports and recognizes professionals who apply infant and early childhood mental health principles to their practice. Endorsement is not a license, but an overlay that complements one's professional license and/or other credentials. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that may distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You will have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it's not visible, click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, and we will address them during the Q&A portion of today's presentation. We are very excited to have with us today Wendy Bender, Executive Director from the New York State Association of Infant Mental Health, and Evelyn Blank, Associate Executive Director of the New York Center for Child Development and Director of New York City Training and Technical Assistance Center, TTAC. Before we turn it over to our presenters, I'd like to let everyone know that by participating in this webinar, you are eligible to obtain 1 continuing education contact credit. CEs are available for social workers and licensed mental health counselors. Please follow the instructions on the next 2 slides to assess the CEs. This link is currently in your chat box along with some instructions, but just to review briefly, you'll need to create a user and password on the portal, find today's webinar under online training to register, and complete the required steps. After you register, you will receive an email with the evaluation link. Complete this and then log back within 24 to 48 hours. Find your registrations, then take assessment. Once you've completed the assessment, you'll be able to download your CE certificate. Once again, thank you for joining us, and I will now pass it over to Wendy and Evelyn to get us started.
Hi, everybody. This is Wendy Bender. Diana, thank you for doing the overview of the objectives. Just to put this up here, these are the things that we will be covering today. And I just want to give everybody a real welcome in joining us. There is a lot of interest in working with young children across the state, and that's just warms the heart of both Evelyn and I. So I want to introduce myself. I'm Wendy Bender. I'm the Executive Director with NICE AIM, and we're a statewide organization supporting the professionals from multidisciplinary fields. We also, and we're going to be talking about the endorsement, promoting a uniform and nationally recognized standards and competencies to ensure that those who are engaged in the multidisciplinary field supporting young children and their families are trained in science of child development and relationship practice. If you haven't found us on Facebook, we certainly encourage that you do so. We post infant mental health related content daily, and it's just a great place to connect with each other. Thank you.
And this is Evelyn Blank, and I'm pleased to be here today and really want to thank everybody for joining us for this second webinar. I want to explain who we are. I'm from New York Center for Child Development, and New York Center has been a major provider of early childhood mental health services through a variety of federal, state, city, and philanthropically funded programs. We have a long history of providing system-level expertise to inform policy and support the field of early childhood mental health. And we do this both through training and direct practice. We're also really excited to be selected by the New York City Department of Health and Mental Hygiene under Thrive New York City to develop a citywide early childhood mental health training and technical assistance center. And quite pleased to say that our subcontractor in this contract is New York University McSilver Institute for Poverty, Policy, and Research. And they offer clinic, business, and system transformation support statewide to all behavioral health providers. And I just want to say that this has been a wonderful marriage. And as we talk today in terms of kind of blending policy with practice, I think we also really need to think about how do we really develop sustainable practices. And I think that McSilver has brought a real kind of knowledge and a level of expertise around really how do you blend practice and business. So we've been extremely excited about it. There's a link here to our website, ttechnewyork.org, and I want to let people know that we will be posting on their trainings as we do them. This is a definite resource for people who are interested in learning more. So thank you for joining us today. And I've been asked to do a kind of brief overview of kind of last webinar and some of the things that we covered. And I do this both as a refresher, but also as a background. We're going to pick up on some of the concepts that we presented last time. So that I want to start by what is the definition of infant mental health. And I think we define it as the capacity of the child from birth to age 5 to experience, regulate, and express emotions, to form close and secure interpersonal relationships, to explore the environment and learn. And exploring the environment and learn is something we're going to focus on a lot today as we talk about attachment and how critical this is for the development of infants and toddlers. And all of this, of course, is in the context of the family, the community, and culture. So I wanted to go over some basic principles. This is going to be kind of a fast fly through some of the things that we talked about last time. But really, I think one of the most important points that we were trying to make last time is why early childhood is a critical window in which to intervene where we can have maximum impact. And I wanted to go through some of those concepts. And I'm going to start by saying that 85% of brain development occurs before age 3, which I find a pretty startling statistics. And what we also know is that there's a high prevalence of children who are experiencing social emotional problems that negatively affect their functioning, development, and school readiness, anywhere between 10 and 14% of young children. So this is a significant issue. Children are really struggling here. We also have seen Walter Gilliam did a lot of work on preschool expulsion, which this took a time for me to wrap my head around, that we could be expelling preschoolers. What a bad trajectory here. But we found that they have high rates of expulsion, 6.7 children out of every 1,000 children nationally. So this is really a crisis. And I think that part of what we want to really do is create the platform here about why this work is so critically important. We also talked about return on investment and James Heckman's work. He was a Nobel Prize economist who found that interventions early in the life cycle of disadvantaged children have much higher economic returns, and most highest returns were in the birth to age 3. So we talked about the fact that investing in young children makes good economic sense. And I also talked about several policy initiatives, not that we're going to go into them here, but talked about the first 1,000 days on Medicaid, where New York State Medicaid under Jason Helgerson has launched a first-in-the-nation initiative to develop recommendations for how Medicaid could improve outcomes for children in the birth to 3 cohort. And we did put resources at the end. We talked about some of the policy and opportunities in New York State. I would encourage people to go to the links and really to explore this further. We also touched on the adverse childhood experiences, which I'm sure everybody is very familiar with. But they did a study finding that children exposed to 4 or more adverse childhood experiences correlated positively with a range of lifelong physical and mental health problems and increased health risk behaviors. So I think that we've learned that what happens in early childhood really has long-term consequences for both health as well as mental health. And we also spent some time talking about toxic stress and complex trauma. And we've learned that chronic stressful conditions such as extreme poverty, abuse, severe maternal depression, or other trauma can actually disrupt the architecture of the brain and lead to lifelong difficulties. And this is in the absence of having a nurturing adult who can really help buffer the stress. Domains of development are intertwined, and I bring this in because so often we bifurcate mental health and early childhood development, and particularly for young children, the lines of development are intimately and inextricably interrelated, so that they really are very feeding onto each other, and that emotional development is integral to mastery in all related areas upon which other development builds. And this is an important concept. We'll talk about it a little in terms of early intervention as well. And if there was one takeaway message from the first webinar, it's about relationships, relationships, relationships. We talked about the critical and the central role of relationships with caregivers in the early years. We know that children come into the world totally dependent on those who care for them. And we quoted Winnicott, who said there's no such thing as a baby, but only a baby in relation to the mother. And it's really the consistency and quality of early relationships, as Jack Shonkoff would say, that helps to set the stage for a sturdy or fragile existence. We talked about the importance of attachment, which was the capacity of the caregiver to be sensitive to the child's cues and also to respond empathically to emotional signals. And it provides the foundation for the child's secure and healthy development. And we're going to talk a lot about this today and how important it is in terms of the ongoing work. And we ended with talking about resiliency, and this is the positive note, and the importance of strong buffering and nurturing relationships, which can make the critical difference for young children. So today I'm going to start off by saying, what is infant mental health practice? So I'm going to quote Zena and Zena here. It says, the field of infant mental health may be defined as multidisciplinary approaches to enhancing the social, emotional competence of infants in their biological, relationship, and cultural context. And what point I'm making here is that early childhood mental health is not the responsibility of any one discipline or field, but all professions who are touching the lives of children. And all of those working with young children need to be mental health informed. So that I think that the idea that not just mental health practitioners, but everybody working with young children is really critical when we talk about mental health practice. I also want to talk about the importance of early identification. We've talked about the return on investment. We've also talked about the critical window here. And one way to really reach children early is through standardized screening. And I'm really pleased to say that the American Academy of Pediatrics has recommended routine universal developmental screening at certain key points in well baby visits at 9 months, 18 months, and 30 months of age. And I think that primary care is a wonderful venue in which to identify children. It's very non-stigmatizing. It's part of a well baby visit, and it's like checking the other vitals for a child. But for children birth to 3, it's the one universal venue in which all children go. It's also important, I think, to screen for social emotional challenges as well as maternal depression. Screening can be presented to parents as a routine way of checking the child's development to get well-established norms. It can help clarify whether behaviors that the parent is seeing are age-appropriate or whether there is a need for further assessment. One of the things that we really try to do is to encourage parents to be partners in monitoring their child's development. And there's a website, Born to Thrive, that talks about the importance of developmental screening and also supports something called a developmental screening passport. And it's a wonderful tool where each time the child is screened, it's entered into a document that the parent can bring with them. And it's really important because we find that children are screened in multiple settings, but that the settings don't often talk to each other. It's important whenever screening a young child to explore whether there's been previous screenings and also what the parent's understanding was of the findings of that. And I think that what's most important when screening young children is to emphasize that if a child is found to be at risk, it's not a diagnosis, and it's only an indication that some further evaluation is needed to try and find out what might be going on. And that it's very important that whenever screening is done, that these results are shared with the parents with next steps where indicated. It's beyond the scope of this webinar today to really give you a compendium of all the existing screening tools, but I thought I would highlight a few key tools. And just to know that at the end of this, I've put as a resource a compendium of all the screening tools that are available. But the ages and stages, both the social, emotional, and the developmental, are really key tools that can be used. The ASQSE screens 7 key emotional areas: self-regulation, compliance, adaptive functioning, autonomy, affect, social communication, and interaction with people. And this is a great tool in identifying children who actually may be at risk. The ASQ3 is an assessment tool that helps parents provide information about the developmental status of their child. And again, this is across 5 developmental domains. So communication, gross motor, fine motor, problem solving, and personal social. And just to note that both in early intervention and CTSE, these are domains of development that are assessed. And then lastly, also the importance of screening for maternal depression. We talked last time, we'll talk briefly today about some of the consequences of a depressed parent. But there are easy tools, the PHQ-2, which is a 2-question tool, or the PHQ-9, that can really assess the presence and severity of mental health depression. So when we're talking about young children, it's very important to assess the parent-child relationship. Since young children develop in the context of their primary caregiving relationships, it is essential to assess both the quality and consistency. And any disruptions in the caregiving relationship really impact on the child's development. So the quality of caregiving relationships is really critical, but it's also co-determined by the mutual influences on the child on the caregiver, and the caregiver on the child. And it's thought to have a profound impact on the social, emotional, and cognitive development of the child. And this is what we're going to focus on a lot today. So in assessing the parent-child dyad, we need to recognize that stresses can come either from characteristics of the child or characteristics of the parent or the interaction between both. So as an example, a child may exhibit different temperaments and different levels of development. A child may be difficult to soothe, may have different sensory profiles, may have developmental challenges or delays. And the adult may have a differing ability to attend and respond to the child's needs. They may be depressed. They may have their own history of inadequate or abusive parenting, which interferes. And we're going to talk about this intergenerational transmission and how they go from one generation to the next, and these patterns and styles are transmitted. So the ability to adapt and respond to each other is the basis of a mutually satisfactory relationship. And Barnard terms this mutually adaptive dance, which I think is a really beautiful kind of term in terms of thinking about how to look at the interplay between these. So that when we're treating young children, it's important to work within the context of this caregiving relationship. And so effective treatment and interventions are usually relationship-based and include the child's primary caregiver. And it's also an intergenerational model that it really looks at kind of parents' own pattern of parenting and kind of how these get transmitted over the generations. And it's also important that part of treatment is to provide developmental guidance to help parents to understand age-appropriate developmental expectations of their child and also strategies based on the individual profile. And again, it's really important to understand the overall developmental profile of the child and how this really impacts on the relationship between the mother and the child. We talked last time about goes to the nursery, and this is a really key concept and one that I want to kind of reinforce again. Freiberg and her colleagues in 1975 introduced this metaphor called goes to the nursery, and they used it to describe the ways in which parents, by reenacting with their small children scenes from the parents' own unremembered early relational experiences of helplessness and fear, transmit child maltreatment from one generation to the next. So parents often, relive their own childhood relationships. So negative attributions are connected to earlier experiences. So if you hear a comment like, he's just like his father, which is attributed to an infant, it may be a sign that the parent is confusing past relationships with the present. And this in turn can impact on the parent-child attachment and certainly on the child's behavior and reaction to this. Conversely, and this is a concept that was developed by Alicia Lieberman, who's one of the architects and developed child-parent psychotherapy. And today we're going to be talking about some evidence-based practices, but also not really supporting any one. I do want to let people know that at the end of this webinar, I also put a compendium of evidence-based practices in working with infants and parents. But conversely to ghosts in the nursery, the metaphor of angels in the nursery refers to positive caregiving relationships. And these are in the parent's past where they feel safe, accepted, and loved. And these are experiences that can be drawn on when the child becomes a parent to help interrupt the cycle of maltreatment. And I love this next line, but Alicia talks about uncovering angels as well as exorcising ghosts in the lives of traumatized parents are important forces in doing infant-parent psychotherapy. There's also a concept of goodness of fit that's very important, and we talked about the different styles of and different developmental levels and different kind of pieces that each child and characteristics that each the parent and the child bring to it. But in looking at the relationship, it's also important to consider whether there may be a mismatch between the child's individual characteristics, such as temperament and developmental functioning, and the characteristics of the caregiving environment. So that when we see problem behaviors, they may reflect a mismatch between the child and the caregiving environment, developmentally inappropriate caregiver expectations. And remember, we talked about the importance of really helping to make sure that the parent has realistic expectations for the child at their developmental level, or limitations of the caregiver to meet the child's needs. So that it's really important to say not only is it the individual characteristics of one or the other, but it's really the interplay or the dance between the two of them and how they fit together. And of course, it is really important to be culturally sensitive in the practice. And I think that we know that different cultures and different families have different styles of raising their children and very different expectations. And it's critical that we don't impose our own biases or beliefs on the families that we're working with. So in working with young children and parents, it's important to recognize and be sensitive to diverse values, beliefs, practices, and expectations related to child development, emotional health and well-being, and child rearing practices. So it's important to understand parents' views of child rearing and the cultural explanations of a child's behavior. Parents' concerns may differ due to differences in background, beliefs, and expectations, and I'm sure that you see this all the time. So therefore, two children can exhibit the same behavior, but differences in cultural norms and expectations will either normalize or minimize behavior or make the behavior important, so that the parent's own report of it can be very different. So what may be normal and kind of expected for one family may be very different and kind of culturally unacceptable in another family, and this is important to really take into account here. Critical to any assessment of the parent-child relationship is also the quality of the attachment between the parent and the child. And attachment is the capacity of the caregiver to be sensitive to the child's cues and respond empathically to emotional signals. And this really provides the foundations for the child's secure and healthy development. And we're going to talk a lot about attachment today. And last time, Wendy kind of highlighted some of the different styles of attachment. And secure attachment provides the base to explore the world for a child and a safe base to return to in times of need, and provides physical safety, and it provides resilience to stress and helps the child in terms of self-regulation, and also forms the basis for healthy, meaningful relationships. We also talked about different styles, and I'm not going to spend a lot of time on this today, but we talked about ambivalently attached children. And these are children who are often reluctant to explore the environment. And when we talked about what is infant mental health, we talked about the ability to explore the environment and learn. So the children who are really reluctant to separate and kind of move out from the parent really don't have the experiences that they need to really kind of grow and develop an autonomous identity. And often it's a result of a parent who is inconsistently attuned and maybe sometimes sensitive, but also sometimes neglectful. And these children cannot depend on their mother or caregiver to be there when needed and cannot rely on having their needs met. Likewise, children with an avoidant attachment tend to avoid parents or caregivers. And when offered a choice, these children may show no preference between a caregiver and a complete stranger. And research has suggested that the attachment style might be a result of abusive or neglectful caregivers. So children who are punished for relying on a caregiver learn to avoid seeking help in the future. So how do we support secure attachment? And these are just some strategies. These were taken from Circle of Security. And again, I just want to say that it's beyond the scope today to really go into the whole kind of range of evidence-based practices. We're going to talk briefly about CPP, Watch, Wait, Wonder, but also Circle of Security, which is a really attachment-based intervention with families. And I think it's got some key strategies and principles about really helping parents and children in terms of this attachment issue. And so some key strategies in working with the parent and the child are helping the parent to understand the child's cues and increase the caregiver's sensitivity and responsiveness to the child's signals relative to their moving away and returning to the parent for comfort and support. So I'm going to show you a graphic from Circle of Security that really kind of reinforces the importance of this kind of ability to move away and also to come back for kind of refueling to the parent. We also want to help parents to increase their ability to reflect on their own and their child's behavior, thoughts, and feelings, and to see how this really impacts on their caregiving relationships. And again, as we said last week, or in the last webinar, that we know that attachment styles are transmitted intergenerationally. And so it's very important for parents to understand how what happened to them may be being replayed out in their own relationship with their child. And this is a graphic that I just love and I use often, and it's from Circle of Security. And it's a graphic that provides a learning tool for parents and really used to help them see, understand, and support their child's attachment and exploratory needs. And the idea is that when children feel safe, they are hardwired to be interested in the world around them and to explore. And that when children move away from the parent, they look to the caregiver to be a secure base. Sometimes they want their caregivers, as it says on the graph, to be with them and watching. Sometimes they need help, and sometimes they want their parents to enjoy or delight in their play. And while exploring, children inevitably need to return to their base. I call this kind of a refueling, to be closer to their caregiver because they may need help with their feelings, protection, comfort, or to organize their feelings. So in this grid, the top half really refers to the child's ability to use the caregiver as a secure base. And I think that as we've been talking about, that the parent's comfort with this may be really influenced by their own past. So that some parents may feel uncomfortable or threatened by their child's exploration when the child moves away, whereas others may have negative feelings in response to their child's attachment needs. And this is usually based on their own earlier experiences, and it's something that we want to work on in the ongoing treatment. The bottom half refers to the child's ability to use the caregiver as a safe haven to come to for comfort and protection and to negotiate the needs for closeness. And by attaining closeness with a responsive caregiver, a child's distress will diminish and the child will feel more secure. And the hands really represent a secure base where the child can go to refuel and to really get the support and the comfort that they need. The concept that they use are always being bigger, stronger, wiser, and kind. And the idea here is that sometimes parents take charge and they want to be bigger and stronger, but they forget to be kind to their kids, or at other times they try to be kind and they really give up their leadership role and abdicate, and their child ends up running the relationship. So that the real kind of concept here is encouraging parents to respond to their children's needs unless there's a need for them to take charge. So this is just a nice graphic that can be used in working with parents and children. It's also critical when working with parents and children to be responsive to the needs and the parent's mental health. And I'm not going to go into great depth here, but we know that something like maternal depression may really impact on the parent's ability to be there for a child. And again, this is something that's treatable, so early identification is really critical. But just some examples, that it may compromise the mother's judgment on supervising health and safety, and they may be less available emotionally in order to really help develop a positive attachment to their child. We talked about chronic stressful situations and complex trauma and how devastating this can be for children without the buffering protection of an adult. And I just want to say that the greatest source of danger, unpredictability, and uncontrollability for an infant or a young child is the absence of a caregiver who reliably and responsibly protects and nurtures the child. So that a primary goal in working with traumatized children is to support and strengthen the relationship between the child and his or her caregiver as a vehicle for restoring the child's sense of safety, attachment, and appropriate affect, and improving the child's cognitive, behavioral, and social functioning. For those who are interested in kind of exploring Alicia Lieberman's whole model of evidence-based practice, it's child-parent psychotherapy, and it's a wonderful model for working with traumatized kids. So I'm going to turn it over to Wendy, who's going to talk about some of the competencies of and working in infant mental health.
I think Wendy's line might be on mute. Wendy, can you please unmute your phone? Apologies, everyone. One moment while we fix this issue. Hi, Wendy. Can you hear me?
Oh, I'm sorry.
No problem.
All right. Sorry, everyone. I hit the wrong button. So just backing up, those other slides are really talking about sort of the beginning of developing standards and competencies across the board, starting with the Michigan Association for Infant Mental Health being supported by 0 to 3. And I just wanted to mention this area of knowing, doing, and being. That the knowledge is a very important part of this, but it's also really important to recognize that knowledge alone is not enough. And if you're anything like me, I have a bookshelf that I refer to as my shelf of shame, because it's filled with great ideas and notes and handouts and resources that I've collected from trainings. And it's so much more than that to be able to build proficiency and competencies. So reflecting not only on the knowledge that I have or that I've gained, but also reflecting on doing. How have I incorporated this knowledge into my day-to-day practices? What does it look like? What does it sound like? And how do I know that I am doing this? And then the last concept here is being. And as Jeree Paul said, how you are is as important as what you do. This is relationship-based work. And how we are has a huge impact on the relationships that can be developed. So I just included this little slide to talk about the acquisition of competency. And I think sometimes we think of competency as something that you either have or you don't have. And I like this stages of learning concept because I think it really talks about how the process of developing competency, going from an unconscious incompetence that I don't know it and I don't even know that I don't know it, to a conscious incompetence where I'm beginning to know it but I really don't know quite how to do it, a conscious competence where I'm beginning to learn it and I'm beginning to do it but I've got to think my way through it and be totally present all of the time to be able to incorporate it. And then the last stage of unconscious competence, which says that, this has become second nature and can be easily performed, and I can even do it while I'm doing other things. So the NICE endorsement, I'm going to be talking about that, is a shared framework across disciplines. And I think this is important. Evelyn mentioned that, and that is just a key piece of this. This is really designed to be across disciplines, everyone that is working in this field. It's a guide to development of knowledge, skills, and best practices. It provides a foundation for our knowledge, invites a collaborative dialogue between practice, training, evaluation, and professional growth, and it promotes systems growth and change. The endorsement is intended to recognize experiences that lead to competency. It is not a licensure or certification, but it's meant as evidence of specialization in this field, cross-sector and multidiscipline, and it indicates an individual's efforts to specialize in this specialty. It's important to consider that different disciplines have a very different scope of practice in their work. So the endorsement is divided into 4 separate areas, really focused on, they're not hierarchical, it's really focused on, it's dependent on the primary focus. So the infant family associate, which is primarily focused on promotion, might be somebody in child care, it might be a pediatrician, it might be a nurse, it might be a family court judge. The infant family specialist is primarily focused on prevention. So this might be somebody in early intervention, maybe home visiting. Infant mental health specialist is primarily focused on treatment, and these are the mental health clinicians and supervisors. And then the last is the infant mental health mentor. And this particular category is divided into 3 areas. So this is a group of folks that are primarily focused on supporting the workforce, and they can come from a clinical, faculty, or a research policy bent. I just wanted to give you a little peek. The endorsement is based on competency areas, and if you look at the left-hand side of this page, you'll see that there are 8 competency domains going down on the left-hand side. So theoretical foundations, law, regulation, policy, direct service skills, working with others, communicating, systems expertise, thinking, and reflection. And on the right-hand side, it just gives you some samples of the knowledge areas and skills that they're talking about under each of these 8 domains. I'll just give you a moment to take a peek at that. On this slide, I've taken just the first area domain, the theoretical foundations, and the right-hand side of this is listing, this is as demonstrated by, this is what it would look like. The endorsement process is portfolio-based. So it's really you taking a look at your own history, your education, and college courses you've taken, any specialty training, as well as any work and on-the-job learning experiences that you've had. So if you look at this slide as just an example, the idea is building your portfolio by looking at these areas as demonstrated by, and then looking back at your history and saying, how have I met each of these competency areas? And what typically happens for most people as they begin to build the portfolio is they identify some areas that, oh, I really haven't had specific training in that. That is something that I'm going to need more of. And there's one other thing that I'd like to spend a little time on, and that is that a key component of this is reflective supervision and consultation. So as you know, this is very hard work, and it's easy for each of us to have strong responses and reactions to the experiences that we see before us. Learning without reflection is a waste. Reflection without learning is dangerous. We do not learn from experience, we learn from reflecting on experience. So a critical component of reflective supervision, which is a critical component of the endorsement, focuses on this ability to reflect and learn. And I want to talk, I get a lot of questions asking what are the differences between administrative, clinical, and reflective supervision. So I wanted to spend a little bit of time talking about that. Many practitioners receive administrative or clinical or clinical supervision, but reflective supervision is often optional. Reflective supervision often includes administrative elements, and it's always clinical, but administrative and clinical supervision are not always reflective. When it comes to administrative supervision, you're looking at things that relate to the regulations, rules, policy, procedures, might focus on hiring, training, paperwork, reports, rules and policies, as well as coordinating and monitoring productivity. Clinical supervision, while it is certainly case-focused, it doesn't necessarily consider what the practitioner brings to the intervention, nor does it necessarily encourage the exploration of emotion as it relates to working with young children and families. So this might include reviewing casework, focusing on diagnoses, interventions, treatment plan, evaluating progress, and providing guidance and teaching. Reflective supervision is distinct. Due to the shared exploration of the parallel process, which means attention to all relationships is important. That includes the one between the practitioner and the supervisor, between the practitioner and the parent, and between the parent and the child. And it's critical to understand how each of these relationships reflects on the other. Of additional importance, reflective supervision relates to professional and personal development by attending to the emotional content of the work and how our reactions to the content affect the work. There's greater emphasis on the supervisor's ability to listen and wait, allowing the supervisee to discover solutions, concepts, and perceptions on his or her own without interruption from the supervisor. So a couple of key components with this include forming a trusting relationship between the supervisor and practitioner, establishing consistent and predictable meetings and times, asking questions that encourage details about the infant, the parent, and the emerging relationship, spending time just listening, remaining emotionally present, teaching, guiding, nurturing, and supporting, as well as integrating emotion and reason, exploring that parallel process, and attending to how reactions to the content affect the process. In sum, it's important to remember that relationship is the foundation for reflective supervision. All growth and discovery about the work and oneself takes place within the context of this trusting relationship. And I'd like to share two quotes that I think really capture this. The first is from Rebecca Chinook, and she said, "When it's going well, supervision is a holding environment, a place to feel secure enough to expose insecurities, mistakes, questions, and differences." And from Jury Paul, supervision is a place to understand the meaning of your work with a family and the meaning and the impact of your relationship with the family. So here are a few reasons why someone might be interested in pursuing the endorsement. There are a few states that have been at this for a very long time and are working at including into Medicaid reimbursement that a clinician needs to have the endorsement to be Medicaid reimbursed. To date, there are over 2,000 professionals who have earned the endorsement, and more than 1,000 more are in the process, We're one of 29 states that are using this endorsement process. I hope you might be interested in this. I hope this has tweaked your interest, and please take a visit at niceaim.org to take a look at the endorsement, and certainly contact us if you have any questions.
So I wanted to thank everybody for joining us today, and I thought I'd just give some kind of summary remarks, and we did want to leave time for questions that people may have today. But I think if there's one thing that we've wanted to get across, it's that just that early relationships and experiences really do set the stage for a sturdy or a solid foundation for the rest of children's lives. So that in working with young children, it's important to not only evaluate the child's development, the well-being of the parent, but also the relationship, which is the context in which we often work. And that what we're looking for is working in the context of the caregiving relationship to support mutual competence by both the child and the parent, and also to help the parent to reflect on their own and their child's behavior, their thoughts and feelings regarding their attachment caregiving interaction, and help them to establish more effective caregiving patterns. So that when we're talking about early childhood mental health, we're really talking about trying to break this intergenerational cycle that oftentimes is passed down from one generation to the next, and usually unconsciously. So someone who's been abused ends up being in abusive relationships. And we feel like early childhood is really the moment to really kind of intervene and try and break this cycle. And we should need to include, obviously, attention to understanding parents' views of child rearing and their cultural expectations of a child's behavior, which differs based on everybody's own culture and beliefs. And we also talked about the idea of competency as determined by expert consensus, require the development of a unique knowledge base, clinical assessment, and intervention treatment skills specific to infancy and early parenthood. And I want to stress this because so often we first started doing the work around early childhood mental health, people just started trying to age down what they did with older children. And I hope that what we've conveyed in these two webinars is really just the fact that this is different work, and it needs special competencies and expertise. And lastly, we hope we piqued your interest around the New York State Association of Infant Mental Health Endorsement, which provides a framework across disciplines of infant and family field to promote high-quality, relationship-focused practice and relational health beginning in pregnancy and including the first year of life. So thank you for joining us. I just wanted to let you know some of the resources that we highlighted at the end here so that if you're interested in exploring it more. First of all, we didn't see the kind of focus today of telling you the kind of compendium of all evidence-based practices, but I direct you to SAMHSA's website here, and also screening tools that are evidence-based in terms of what's available. This is the link for First 1,000 Days on Medicaid, and it's an extraordinarily exciting group that came together and is really kind of focusing on a 10-point plan for New York State. And I hope you'll watch this. It's been a real cross-disciplinary, cross-discipline effort, and I think that we're going to see some real outcomes for young children. We also talked last time about the fact that early intervention, as we talked about social-emotional development being kind of the foundation for all other development, has really developed a guidance document here to really educate the field. And this is the link to that publication, which was written not only for early intervention providers, but providers working with young children. And lastly, but not least, the, sorry, I just double-clicked here, but the New York State Blue Ribbon Committee, the report on, click happy here, sorry, report on the status of girls and women in New York, which really has some exciting initiatives around maternal depression. So thank you for joining us. I'm going to turn this back over for questions, and thank you all for participating.
Thank you so much, Wendy and Evelyn. Yes, we are now going to begin answering the questions submitted during today's presentation. As a reminder, you can still submit your questions through the chat box. So our first question is, are the ages SE and ASQ3 free in the public domain?
They're not free, but they are available, unfortunately. And I think a lot of people have referred to the SWIC, which is free in the public domain. so unfortunately not.
So if someone just Googles that, they'll be able to get additional information as to where to get it, or how would they go about that?
Right. It's in the resources. There's a compendium there that lists all of these screening tools, and people can go look at it. The SWIC is there, as well as the ASQSD and developmental.
Great, thank you. Another question, a little bit twofold. Do you have any recommendations for service providers and or clinics for low-income families dealing with early childhood difficulties and parental depression in New York City? Second part is, and or play therapy and creative arts therapy resources.
Well, since I'm in New York City, I'll take that one, Wendy, if that's okay. And I just am excited to say that under Thrive New York City, there are now 7 early childhood treatment centers that are really specializing. We are the Training and Technical Assistance Center that's really helping to train and work with those centers. And I don't know the best way to get it to you, but if you go to our website, the Thrive New York City, you can see those treatment centers, and they have experts there who really not only do mental health consultation, but also know how to work with parents and children. And I know that some of them do have allied professionals. I know of one site specifically that has art therapists on the board. So we've really tried to make it a kind of multidisciplinary kind of intervention there. And people can reach out directly to me if they want more information.
Great, thank you. Let's see, once you receive the endorsement, how can you apply it to your job and or life every day?
One of the biggest things that we've heard from people who have gotten the endorsement is just the building process of reflecting on the work that you've done and preparing yourself through the process of building this portfolio and taking an exam at some of the categories. It really just sort of centers you on the work and brings the focus into what it is that you're doing by focusing on meeting all of these competencies and how do I meet all of these competencies or seek training to meet them. It really just brings that into focus. At this point, it is still a very new thing in New York. We currently have 13 people that are endorsed here in the state of New York. That is definitely going to be increasing over the next several years, and I see this as a big draw for an employer to be able to have somebody who has the endorsement.
Great, thank you. Let's see, our follow-up question. What would you recommend to engage parents to explore their own behaviors or upbringing history without having the parents be defensive?
Well, I think that one of the whole principles is that first you need to develop and establish a safe and secure base for the parent in the treatment relationship. And so I think that that's a gradual process. I think that as parents, it's a parallel process there as they feel more secure, more open to looking at it. And I think what we want to do is do this in a very kind of non-threatening, non-defensive way and really build on positive interactions, but also really help a parent to find more successful strategies for working with their child. So success breeds on success, but I think that it really needs to happen in the context of relationships. And one of the key principles in circles of security is that before you can really help a parent to reflect on their own kind of relationship with their child, they need to feel safe and they need to be in a secure safe haven for themselves.
Great, thank you. So the recommended screenings include screening for maternal depression. What about parental depression or other mental health substance abuse problems?
You know, I mean, I must say, I was in a forum yesterday, we were talking about Bright Futures, which is the AAP kind of recommendations for best practices. All of these are important, and I think that part of the key is really having some judgment differential understanding in terms of when and what tools to apply when. All of these things profoundly impact on a child, and I think that if you suspect adult mental illness, if you suspect a parent who's excessively stressed, that it is really critical to really explore that further. This is not kind of the sum total of everything you should be looking at. Maternal depression is one that I think has been singled out partially because of the fact that it's treatable, and there's that it's unnecessary for parents to really go through this without the right supports and help that they need. We are not minimizing parents with cognitive delays, with substance abuse. These are all really critical factors that impact on attachment.
All right, thank you. Our next question, I'm wondering how the reflective supervision can be implemented in child welfare, in particular children who have been placed in foster care.
What a great question and what a great need. I mean, what a perfect example of anybody who is working in that field, the impact that it has on us. And one of the, that's, I think that's across the board in, any kind of any of this kind of work. But when you're dealing with very young children, all of us we have our own experiences that we bring to this work. So not only are we impacted by what we see, we're impacted by our own experiences that get churned up in this. So bringing reflective supervision or consultation into that field, I think, is critical. Not easily done, but I think it is just such an important piece.
All right, and what is one recommendation or habit you would provide to new parents to help ensure a healthy, secure attachment with an infant?
Well, it's tough to say. I mean, I think that, what we really want to do is, rather than giving advice, is really help them to rejoice and enjoy and celebrate their child. And so I think that any way that we can really reinforce that relationship and really remove barriers, the better. So I think that, parents really want to connect with their children, and I think come in with high expectations, and anything that we can do through some of the strategies that we've talked about here, I think are really critical to help form a secure attachment between the adult and the child.
All right, thank you. And our final question, because I do see that we are coming up on time, where can I get the information on the complete reflective process in order to incorporate it better in my scope of practice as a public health nurse home visitor?
Send us an email at Reach Us at NICEAIM on that blog that I offered. Our intention is to get some more of this information up on our website. It's not there yet, but I can certainly give you some references of where to find that.
Okay, and the best way to reach you, I know just unfortunately on our screen we don't have your contact information, but if you can just maybe verbally verbalize it, but I was told that it's actually just in the chat box as well. So this is the best way to reach you, right?
Reach us at NICEAIM.org. Yep.
Okay, great. So once again, I do want to thank Wendy and Evelyn, and thank you everyone for attending today's webinar. If you have any other questions, certainly feel free to contact Wendy and Evelyn. You can certainly contact us at ctech.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. On behalf of CTech and our presenters, thank you for joining us today, and have a great rest of the day.